Good afternoon, all. A very warm welcome for our 12th episode of Academics with Institutions. We have come a long way involving all the medical colleges from all the 5 zones. Today, we are having the North Zone Medical College, that's Himalayan Institute of Medical Sciences from Dev Bhoomi Uttarakhand. So, hearty welcome to all of you for this 12th episode. I welcome our National President, our respected Dr. G.V. Basavaraj sir, our President-elect, Dr. Vasant sir, our HSG, Dr. Yogesh sir, and our past presidents, Dr. Pramod Jog sir, thank you so much for joining in, and our Senior Vice President of North Zone, Dr. Satish Sharma sir, and a warm welcome to the faculty from Himalayan Institute of Medical Sciences. Welcome our Chief Guest, Dr. Vijendra Chauhan sir. Thank you so much for accepting our invitation to be on board in our Academics with Institution. Our guest of honor, a well-known teacher and a great academician, Dr. Ashok Diyarari sir, our guest of honor. Hearty welcome, sir, and welcome all the faculty from the department. I now request our HSG, Dr. Yogesh Parikh sir, to deliver the official welcome address. Unmute, sir.
Thank you very much, dear Dr. Priya Madam. You are doing wonderful work for coordinating this Academics with Institutes. And today we have a 12th episode, and the prestigious institute, Himalayan Institute of Medical Science from the Dehradun, is participating in this wonderful program. So I welcome our beloved President, visionary President, having a mission of the academics with the institutes, Dr. G. Basavaraj, President, Dr. Vasant Kalatkar, Dr. Upendra Kinjwadkar sir, my dear friends, Dr. Atnu Bhadra, and our chief guest, Dr. Vijendra C. Chauhan sir, Satish Sharma sir, our senior vice most president, and Professor Ashok Diyarari sir, and our advisor, Dr. Jagdish Sinappa sir, and zonal coordinator, Dr. Lalit Medirata ji, and Professor Alpa Gupta madam, and Professor Anil Rawat sir, and post-graduation teacher, Dr. Professor Ashish Kumarji, and Dr. Mansi and Dr. Manjot Kaur from the Dehradun Institute. So this is a wonderful program going on, and very well appreciated by across the country, and we are getting the viewers report more than 1,000, 1,500 or 2,000 sometimes. So this is a well appreciated and well conducted program by our Priya Madam and the team under the leadership of Dr. Basavaraj sir and the advisorship of Dr. Jagdish Sinappa sir. So thank you very much for participating in this program. We have a wonderful teachers in the audience, our Srinivasan sir, Dr. Pramod Jog sir, and many past presidents and the executive boards are here to support this program. So I thanks all of you on the joining on the DIP platform. I welcome our President sir for this official presidential remarks.
Basavaraj sir. I think sir lost the network. Sir will join again. Meanwhile, I would request our chief advisor, Dr. Jagdish Sinappa sir, to brief the gathering.
Yeah, thank you very much, Priya, and respected CIAP office bearers and the faculty at the Himalayan Institute. I think this is the 12th episode which we are doing, and this is from the North Zone. We're really excited about this program every week because we see all the institutions that have contributed to the growth of IAP from different zones. Though physically we may be unable to travel to go and meet all of them, to see them virtually and to see all their accomplishments is a great honor for all of us. So thank you very much today for joining in, and we'll have a wonderful program involving all the staff and also the postgraduate students from the Himalayan Institute, Dehradun. Thank you very much.
Thank you, sir. Now I request our Senior Vice President from North Zone, Dr. Satish Sharma sir, who is so enthusiastic and energetic for this program. I would request sir to speak few words and introduce our respected chief guest, sir. Over to you, sir.
Good evening, everyone. Our dynamic and vibrant National President Dr. G.V. Baswaraja, our National Secretary Dr. Yogesh Parekh ji, our National Treasurer Dr. Atanu ji, Jagdish Chinappa sir, Chief Advisor, Chief Guest of today's function, Dr. Vijendra Dev Singh ji, Dean Hims Medical College, Dr. Ashok Durare ji, all other OBs and EBs, all other my colleagues, EB member, all faculty of the Hims present here. Hello, am I audible?
Yes, yes.
Yeah. Something
Yeah.
went.
Sir, our Basavraj sir has
Yeah,
joined.
this is my
Request-
proud privilege to introduce our chief guest of today's program, academic institution. Dr. Vijendra Devi Singh Chauhan is presently the Director General of Academic Development of Swami Rama Himalayan University, and he is Professor of Orthopedic Surgery at Himalayan Institute of Medical Sciences, Jolly Grant, Dehradun. He is also a member of the Presidential Body and Secretary of the Himalayan Institute Hospital Trust. Formerly, he has been Vice Chancellor and Pro-Vice Chancellor of Swami Rama Himalayan Institute and Vice Chancellor of the University. And he was Dean of the Himalayan Institute of Medical Sciences and Head of the Department of the Orthopedics at HIMSS. He is Fellow and Medical Educationist. He is alumni of prestigious Mahatma Gandhi Institute of Medical Sciences, Sevagram, Wardha. Apart from being a medical professional, Dr. Vijendra Devi Singh Chauhan, he conducts regular workshops on mind, body, and spirit through science of joyful living program based on philosophy of His Excellency Dr. Swami Rama. He is a recipient of many national awards, fellowships, and honors for his academic excellence. And I welcome our chief guest, Dr. Devi Singh Chauhan, and for his blessing, I request him to give us blessing for the occasion. Dr. Chauhan, sir.
Sir, before Chief Guest speaks, Dr. Basavraj sir is traveling. I would request him to speak few words.
Okay.
Thank you, Dr. Priya. So, respected all the dignitaries, this is one of the unique program which is involving the postgraduates, teachers, and the practitioners. So, I'm sure that today's deliberation is going to be very, very useful. I'm traveling. Wish you all the best. Please go ahead, sir.
Thank you. Thank you so much, sir. Request our respected Chief Guest, sir, Dr. Vijendra Chauhan, sir, to please address.
Screen share. Honorable President, sir, and Secretary of this great association. I'm audible?
Yes, sir. Yes,
Yeah,
sir.
okay.
Please go
Okay.
ahead.
Honorable President and Secretary of this great association, Dr. Ashok Devradi, sir, doyens of the pediatric world, and participants. It's indeed a great honor for me to be a part of you all today. I appreciate the effort of Indian Association of Pediatrics of bringing the whole medical colleges of this country on a common platform, and especially conducting these small workshops or on a webinars for helping people to come on a platform and share their academia with each and every one of you. I'll just share and give you a small introduction to this great university. I've been associated with this university from day one, from 1994. When I renounced my lucrative practice, was attracted to Swami Rama and started this institution. We built it up from a tin shed, and today it's a full-fledged university. He's the man behind this vision, His Holiness Swami Rama. Just a word about this great man. He was a great yogi and a great philosopher, educationist, and his heart used to weep when he used to see poverty in this region and no hospital facilities. And that's the reason why this institution came up. Friends, he is the only yogi in the world who subjected himself to medical controls. And the experiment which I'm going to describe in brief were done at Menenga Foundation in USA. And it's a published work. Thermostats were hooked on his fingers, and he could create a difference of 10 degrees Fahrenheit between thenar eminence and hypothenar eminence by constricting one vessel and dilating the other simultaneously. ECG was hooked on him, and he could produce an atrial flutter by increasing the heart rate to 300 per minute for 17 seconds. EEG was hooked on his brain, and he could produce a delta wave, a wave which is produced in a sleep state, in an awakening state. And he knew what was happening outside. I have seen him personally performing these. I'm a doctor. I cannot be easily convinced. But when I saw these things happening, I had to believe it. He always used to tell me, Beta, if I cannot serve the God within you and others, then going to temples, masjids, and churches is all hypocrisy. And that's the reason why this institution came up, where the philosophy is to create an integrated healthcare model, where there's an integration of ancient wisdom and modern knowledge and technologies, but at the same time, it needs to be cost effective and should be able to address the needs of the underserved population worldwide. We have several constituent academic units of the university. The first and the foremost is the Himalayan Institute of Medical Sciences. Dr. Ashok Devradi is the Dean and Principal of Himalayan Institute of Medical Sciences, wherein we offer undergraduate, postgraduate, as well as super specialty programs. Around 2,296 students have graduated till last year, and 1,227 postgraduates have graduated. They did their post-graduation from this place and are spread throughout the world. The community medicine runs another special programs. They run MSc Clinical Research as well as MSc Epidemiology. The paramedical programs are also being run by the Himalayan Institute of Medical Sciences. You'll be happy to know that Himalayan Institute of Medical Sciences have been designated by Medical Council of India, formerly, now NMC, as a regional medical education training center of National Medical Commission India, wherein we are catering services and faculty training to 19 medical colleges of North India. We have a state-of-art bioskill cadaveric lab in the anatomy department, the one of its kind in North India, where people from different specialties, especially the surgical specialties, they use this for training the faculty members, the students, the postgraduates. You need to visit this sometime. Our Himalayan hospital is a 1,200-bedded hospital. It's a super specialty hospital. It's an NABH accredited hospital. And we have super specialties in almost all the specialties now, services. Just to give a glimpse of, we have 20 modular theaters. We have a state-of-art intensive care units. We have a 40-bed dialysis unit. We have a central diagnostic and research laboratory building, which is housed in a 4-storied building, wherein biochemistry, microbiology, immunology, virology, TB lab, molecular labs, hematology lab, immunohistochemistry, cytology and histology are at different floors. Just to give a glimpse of those labs. We have a pneumatic chute system for transporting blood sample throughout the hospital. The one of its kind, I think very few hospitals have this. All our labs are NABL accredited. We have a state-of-art radiology diagnostic facilities with us. You'll be happy to know that our hospital has been given the Ayushman Bharat Gold Certificate for rendering the highest number of patients in the Ayushman scheme. 135,000 patients were treated till January. We have a very good cancer research institute It has about 250 beds. And it's a multidisciplinary cancer treatment services. We have a PET scan, bone marrow transplant center there. We also, apart from the modern medicine, we also have an Ayurveda center. Sometimes you should come and experience the Panchakarma therapies which they give. And patient can choose what they want. We also have a homeopathy center inside the campus itself. We have a Himalayan College of Nursing offering BSc Nursing, MSc Nursing programs. We also have a Himalayan School of Biosciences offering biotechnology programs, MSc, BSc programs in biotechnology, microbiology, food science and technology, environmental sciences. We also have a Himalayan School of Science and Technology offering BTech programs in computer science and engineering, BSc in data science, master in computer applications. We also have a management institute in the campus offering BBA, MBA programs and BCom honors. Our yoga sciences school offers BSc Yoga Sciences and MSc Yoga Sciences program. And we also have a Himalayan School of Vocational Studies and Skill Development. We have around 2,902 students enrolled. The faculty strength is 337. And we have more than 3,000 employees with us. We have a very good library with us. Another important dimension of this institution is focusing on rural development. We have a dedicated institute focusing for uplifting the masses up in the mountains. The focus is to develop the rural areas very holistically. We take care of helping them to improve their incomes. We take care of their health needs. At the same time, take care of their education. You'll be happy to know this institution is serving more than 2,000 villages up in the mountains. We have trained more than 1,000 health guides up in the mountains. More than 12,000 ashas have been trained by this institution. You'll be happy to know Ganga upar se nikalti hai, but people don't have a safe drinking water up in the mountains. This institution has provided safe drinking water to more than 550 villages up in the mountains by connecting those tributaries, putting those filter plants so that a woman need not travel 5 kilometers for a safe water. The institution has constructed more than 14,000 toilets up in the mountains. In research also, we are not leading behind. We have around 10 crore of extramural projects going on right now, funded by ICMR, UCOST. Recently, 5 crore project due to hard work of Professor Devradi have come in recently. The institution also publishes around 200 publications every year. In 2023, we published around 300 publications in all index journals. The institution has created around 70 patents till to date and 12 industrial designs, 24 copyrights. Just to give the uniqueness of our university, we have a cost-effective, integrated, holistic approach towards healthcare and education. Rural outreach programs providing doorstep services, yoga and stress management into the curriculum, and integration of technology and medicine. Just to give the glimpse of the campus, we have a beautiful guest house. Whenever you come to this side, you can stay here. This is just a campus so that you have a feel of the beautiful campus. Swami Rama used to say, human being is neither body, nor mind, nor soul alone. Human needs are not just physical. They are also mental and spiritual. And unless spiritual learning is included in the education system, we can never overcome our inner poverty. He used to say, although we all are alive, majority of us experience only the art of existing in the world. Very few of us have really cultivated the art of living. So we have started a beautiful program in the campus. We call it Science of Joyful Living for our students and faculty, wherein we tell them how to integrate body, mind, and spirit. Friends, change is the law of nature. Everything changes. Just as there's a metamorphosis of a caterpillar to a butterfly. The same thing has happened with this institution. We firmly believe that whenever change occurs, change has to be for the growth, evolution, transformation, and betterment of humanity. This is what we started in 93, 94 from a tin shed. This is the beautiful campus. Now we can see the whole aerial view of the campus. Just a vision of one man and hard work of our team. We share a common boundary with the Dehradun airport, so you directly drop in the campus. I'll just share the last slide, which my Gurudev told me. These are his last words. Son, all I have is a gift of love which I received from my master and other sages. The same gift I offer to you. May you receive, retain, and multiply it in your heart. God bless you all. Once again, I thank you for giving me this an opportunity and giving you an introduction to our institute. Thank you very much.
Thanks, our chief guest, Dr. Vijendra Devi Singh Chauhan ji, for your wonderful insight and detail into this university and institute. Started way back in 1990s, and how much growth has occurred during your tenure and all other. So this has become not only India but abroad one of the best university and institute. Thank you, sir, for your blessings and your word of wisdom for us for all this program. Over to Dr. Priya.
Thank you. Thank you so much, Dr. Vijendra Chauhan, sir, for that inspirational talk. I think the students who enter the college, university are truly blessed to be there. Thank you so much, sir. Thank you, Dr. Satish Sharma, sir.
Thank you.
I now request our National North Zone Coordinator of the program, Dr. Lalit Menditita, sir, to introduce our guest of honor, Dr. Ashok Diorari, sir.
Thank you, Dr. Priya. And I think it has been a wonderful program. And I was so much impressed with Dr. Vijendra Chauhan's journey, which has told about the Himalayan Institute of Medical Sciences. I think it is a wonderful journey. And I'm so much impressed with the institution, which started from just a shed. And now it is the leading one of the pioneer medical institute in the North India. Sir, very nicely job done by the people working throughout the day and night for last so many years to make this a wonderful institution. Wonderful, sir. And now it's my honor to, in this program, to welcome our guest of honor, Dr. Professor Ashok Kumar Diorari, sir. First of all, he needs no introduction, but he is wonderful. First of all, a great friend of all of us, a wonderful human being. We always have been approaching him when he was in Delhi, sir. Sir is presently the principal of Himalayan Institute of Medical Sciences, which has been just told to us. And he has moved from AIMS, where he was earlier he was the part of this head and professor of Department of Pediatrics in AIMS. And then he has moved to Dehradun in this institution. And sir has been the past president of the National NNF of India in 2020 and also has served as a secretary of NNF in 1995-96. Sir is Dr. Ashok Diorari is also the head of the WHO Collaborating Centers on Newborn Training and Research for more than a decade now, and has served as a consultant to WHO, UNDP, UNICEF for promoting maternal and child health, and has been associated with very multimodal educational programs along with national leaders on the facilities-based preterm care, newborn resuscitation, newborn screening, neonatal ventilation. Has been an excellent teacher in various modules. In fact, many of the programs I have also gone through with him, and is author of many books being authored by him. And it is really my honor to welcome Dr. Ashok Diorari, sir, who is the principal of this esteemed institute, Himalayan Institute of Medical Science. Welcome, Dr. Ashok Diorari, sir.
Thank you. Thank you, Dr. Lalit. First of all, I think it's a great honor for me that I am speaking in front of all the senior IAP executive board members present in the past, and all the students from different medical colleges and the teachers who have joined in this program. And thank you, Dr. Chauhan, for setting the ball rolling and telling us about our university and the medical college we have here. And you know, I moved from Delhi here after spending 48 years at All India Institute of Medical Sciences because I belong to the state of Uttarakhand. I come from a small village which is in Chamoli district near Badrinath. So I took a decision to move back to my own state to make a difference, in the life of mothers and newborn babies and the community at large, which still has difficulty in access to healthcare, education, and there is a lot of poverty still. So I thought what I'm going to talk in front of the learned audience who is going to be on this digital platform of Indian Academy of Pediatrics. So the thought which came to me was that we need to look at what has to be a role of professional organizations, which are large in number in the country, and the medical colleges for accelerating improvement in newborn health. We all know that we have in front of us the SDG goal of 2030, in which we have to reach single-digit NMR for the entire country. We also know that few of the states already have reached a single-digit NMR, and there are many which are still above 20 NMR per 1,000 live births. In addition, the stillbirth rate in the country due to poor antenatal care and intrapartum care is still equal to the number of newborn babies who are dying in the country. We also know that India Newborn Action Plan is laid for the decade 2021 to 2030, so that we reach this single-digit NMR. And the 6 pillars of this India Newborn Action Plan are not only providing care to newborn babies. It starts from the preconceptional care, the antenatal care, the care at the time of labor and delivery, immediate newborn care, and then essential newborn care for each and every baby. And then a great focus in this is on care of small and sick newborn babies, and then follow-up care once the baby gets discharged to home-based newborn care. We also know at this point of time, there are 6 big organizations, professional organizations, who all have a mandate for improving newborn health, because every country's progress is gauged by what your newborn mortality rate is, what your maternal mortality is. And we know India is making a great progress in each and every dimension, from IT to any sector we talk of. But we need to focus on the health of newborn babies and the mothers much beyond the medical colleges. So I'm talking of not only tertiary care hospitals, private or public, I'm talking of babies and mothers who are there in the community. And for this, we know Indian Academy of Pediatrics, with more than 35,000 members spread all across the country, have a huge role. Many of the members of Indian Academy of Pediatrics are also members of National Neonatal Forum of India, which again has a vision for improving newborn health. In addition, we know Federation of Obstetrics and Gynecology Society of India is interested in improving health of the mothers, but they also are interested in the outcome that the newborn babies must survive and thrive well. In addition, we must not forget that Trained Nurses Association of India and Indian Association of Newborn Nurses are also key players for improving health of mothers and newborn babies. And then we have a big organization, Indian Medical Association, because they have their say for guiding medical officers and all healthcare professionals they have their say, just like Indian Academy of Pediatrics, for making advocacy and policy changes in Government of India and the highest body where we can influence. So all these 6 organizations logo which I put all have role for improving newborn and mother's health. We also know that in the country, while we are talking about newborn deaths, majority of the deaths which take place, nearly 80%, they take place in babies who are low birth weight or premature. And the major causes of death are due to sepsis, asphyxia, and nearly 50% of babies who die, they die due to respiratory distress syndrome. We also know that at this point of time, we have evidence-based, which are based on science also, interventions which can save these babies, which are low cost, but they must reach, we must have good coverage of these interventions, like use of antenatal corticosteroids, which can reduce the respiratory distress syndrome, the need for ventilation, and then early use of CPAP, which normally happens in level 2 units or in medical colleges. But we can certainly prevent sepsis by providing a safe environment to the babies, safe water, safe environment, and then ensuring babies get mother's milk rather than getting top milk. For asphyxia reduction, I know Indian Academy of Pediatrics has, along with National Neonatal Forum of India, is already running a program for training each and every person to make them skilled for attending delivery by running the resuscitation program in the entire country. For the preterm baby survival, we need not high-end technology majority of the time, but what we need is simple interventions which can save these babies. As I said, having safe environment, hygiene, prevention of infection is most important. And then giving mother's milk to these babies can save large number of babies. You don't have to put intravenous fluid in majority of the stable babies, despite they may be 1 kg or 1100 grams. Only unstable babies need IV fluids. Rest of the babies can be given mother's milk for making sure that they grow well, they don't get infection. I already said asphyxia can be prevented not only by having skilled birth attendant. We must have good intrapartum care. We must have good obstetric care at the time of birth, in addition to having skilled birth attendant. So it means if we are talking of saving premature babies, it is not only the job of a medical officer or a pediatrician or a neonatologist. Obstetrician also have a big role. In addition, the nurses who take care of these babies in the units or in the hospital for making sure the mother is getting involved in the care of the baby is also very crucial. I think we have to have a mind shift that we need to involve families in the care of the babies. And I don't have to preach all of you. We know kangaroo mother care is one good example in which mother provides KMC to the baby and the baby grows and thrives well and does not have infection. And the best part is that of the 13% of babies who are born preterm, below 37 weeks of gestational age, nearly 85% of these babies are between about 32 weeks of gestation age. They don't need ventilators to save them. Majority of them are not going to require even CPAP for saving them. What they need is safe environment, mother's milk, use of antenatal corticosteroids, and good care at the time of birth so that we are able to prevent hypothermia to these babies and then apply interventions which are cost effective, good practices for saving these preterm babies. Many minuscule number of babies who are high risk require ventilation. Here is one diagram which was published in 2014 in Lancet series for newborn survival. what it says is that if we are able to provide good intrapartum care, good quality care, we can avoid nearly 41% of neonatal deaths which are taking globally. And if we are able to provide good care to small and sick newborn babies, we will be able to avoid nearly 30%. That means 71% of the deaths which take place in the neonatal periods can be averted by good intrapartum care and a care for a small and sick newborn babies. So here comes the role of the obstetrician, the nurses, the midwives, and the medical officers, pediatricians, and the neonatologists for making a great difference for saving a large number of babies globally and in the country very easily. And here what I have written is good 5 practices for the mothers which we need to implement, and 5 practices for the newborn babies which can be implemented for saving them. I'm not going to go into detail about that, but the worst part which bothers me over years is that despite having science, despite having good evidence, we are not able to implement them. We know at this point of time, early initiation of breastfeeding in the country, Dr. Srinivasan is there, who has joined from US, is only 35 to 40%. That means it is nearly 60% is a missed opportunity that we are not able to initiate early initiation of breastfeeding at the time of birth. And the exclusive breastfeeding rates also are dismally 55 to 60%. Again, 40% missed opportunity. And we know mother's milk is the best milk for the nutrition for the baby. It makes the baby thrive, survive, and prevents infection. Use of antenatal corticosteroid, I said, for babies who are delivering below 34 weeks of gestation age. It reduces the newborn mortality in those preterm babies by 50%, the RDS by 40%. But look at the coverage of antenatal corticosteroids in women who are delivering below 34 weeks. I think it is, the figure would be 25 to 30%, even in good public sector hospitals. Maybe in private sector with big tertiary care corporate hospital, the rates are much better. So I have written 5 practices for the mother. And in the last one, I would say family-centered care, involving families in the care of the babies is so crucial. I think we have to move away from relying on too much on healthcare professionals. The job of healthcare professional is to counsel, to communicate, to win the confidence, to inculcate that good practices are followed by the mother and the family. They are able to identify early danger sign and report early. And then for newborn babies, newborn resuscitation, safe use of oxygen, and notice N5 practice is prevention of infection and use of rational antibiotic. This will go a long way. And there is a gap between what we know and what we practice. I think we need to ask our heart. We need to look at around our team, our resident doctors and the nurses who are providing postnatal care or care at the time of delivery. Are we able to apply these practices which are well-known, evidence-based, backed by science? There is a gap. Unless we accept that there is a gap, we'll not make improvement. And then for that, it is important that we need to teach our future generation of doctors and nurses what is quality improvement methodology, and teaching them management principles, and teaching them how to be a good team maker, and then how to collect a data. I have made a diagram, which is again liked by a lot of people based on the NMR in different districts in the country, what all you need, what interventions you need to do. If we are talking of NMR, which is more than 30 in a state or a district, they need to have better water, sanitation, hygiene, institutional birth, basic nursing care, and then NSSK and home-based newborn care can give them the maximum dividend. On the other hand, if a state like Kerala, Delhi, NMR is single digit, what you need is high risk referral. You need then pediatric surgery care, tertiary care and ICUs. You need competent skilled pediatrician, nurses or neonatologists. But if you have NMR, which is below 16, you need to focus on small and sick newborn care, CPAP and ventilation, especially in medical colleges and districts. And we know at this point of time, we have more than 800 medical colleges. Each and every district also is supposed to have medical colleges. But what we lack is competent and skilled nurses and capacity of these units to provide care. I think it is very important for the professional organizations. Professional organizations need to work very, very closely with what the vision of the state government is, or the central government is, for the planning and implementation of whatever health program has to be done for mother and newborn babies. And for this, it is very important that the medical colleges must also try, or private institution must try to do hand-holding and supervision and training, including quality improvement for at least 4 or 5 SNCUs or mother or newborn units which are around their city. And then there has to be a method through which our professional organization try to create regional resource centers and the state resource centers, not only for newborn babies. These have to be for mothers and newborn babies. And never forget that the nurses also and midwives also in many of the states have to be part and parcel of that. And then we must harness information technology, the new norm for doing hand-holding and supervision of these units. I would say that all medical colleges and nursing college, we must make it mandatory. We should get to the NMC or the INC to get, it is already being done, that newborn resuscitation skill-based teaching workshop should be part and parcel of for the pre-service education. In addition, lactation management workshop should be part and parcel. It should not happen in the 3rd year, 4th year alone. Even the interns need to be exposed to that. And as I mentioned, we need to teach quality improvement methodology also in our pre-service education for nurses and doctors, so that they know what is the importance of data collection, teamwork, and how do you get the maximum dividend. Last 2 slides. So I would say we all can contribute, whether we are working in a private hospital or a district hospital or community center or medical colleges. Each one has a role. And never forget that in a big way in the country, in the villages, we are going to have wellness centers, which are going to be managed by the community health officers, who are only BDS doctors, or maybe these are BSc nurses. We will have to do hand-holding of those people. We'll have to train them, and then even work with the ASHA worker training in long way. So at the end, I would say that we must remember 4 C's, that all the professional organizations and the medical colleges, we know all professional organization, senior executive members many times come from the medical college. There has to be a coordination and the cooperation and communication and convergence to a single focused vision. Vision is improving health of mothers and newborn babies. And for that, IAP has a big role, I would say. National Neonatal Forum of India, FOGSI has a big role, Indian Association of Newborn Nurses, IMA, Trained Nurses Association of India. And then medical colleges are going to be the pillars in each and every state, because whether they are in private and public, they will have to work with the other stakeholders like the NHM, state governments, and the various partners, so that everyone is on board, so that we reach each and every newborn and mother in the community. And for doing this, even we have to keep in mind that there are other players also, like the National Health Authority for Ayushman Bharat, NHSRC, Ministry of Health and Family Welfare, NHM, and then focus has to be on intrapartum care, small and sick newborn care, and then care beyond birth. And this is my last slide. These are all documents which are developed for standard of care for mother and newborn babies by World Health Organization and UNICEF. They are in public domain. They have been contributed by many of the Indian health professionals who are neonatologists, pediatricians, and nurses. They have been part and parcel for creating these global documents. So what we need to do is we need to make sure the best practices, best evidence, we are able to give it to mothers and newborn babies so that we have newborn babies who survive, thrive well, and the families are happy with the care which is getting provided to them. Thank you so much. Thank you.
Thank you, Dr. Ashok Derari, sir. Very nicely put the insight what we all, as a part of pediatrician, neonatologists, as well as part of our IAP people, how we can contribute together to reduce this, to find out, to get closer to that sustainable goals of 2030, sir. Very nicely input. And before I hand over to Priya, any comments from anybody? Before
I would request.
Thank you so much, Professor Ashok Derai, sir. Always were more inspirational to the youngsters and the role of professional organization which needs to be played. Really, which is given a lot of insight into it. Surely our organization will work into that in that line, sir. Thank you very much, Professor Ashok.
Thank you, sir. Thank you, sir.
Thank you, Basaraj sir. Thank you so much, Ashok Devarari sir, for giving a roadmap and way forward for bringing the NMR to single digit. I would request our respected teacher, Dr. Srinivasan sir, for his comments. Srinivasan sir, are you here?
Yeah,
Yes.
I'm there, very much there. So it was a wonderful talk with what he has done practically, and then he has conducted, of course, Kangaroo Mother Care, and Dr. Vishnu Bhatt from Jipmar also had gone, and he has opened, of course, in our neonatology unit. And of course, he has stressed on all the important aspects of neonatal care, from basic to and tertiary care unit. And of course, his passion is well known to all over the world, not only in India, but he is known for his care. And excellent talk, sir. Thank you so much.
Thank you, sir. Namaskar.
Thank you. Thank you so much, sir. I think many of us were waiting for your deliberation. Thank you so much, sir. I would now request our National Treasurer, Dr. Atanu Bhadra, sir, to introduce our chairperson, Dr. Alpa Gupta, ma'am.
Thank you. It's always a pleasure. It is always inspiring to listen to Ashok sir, Dr. Devarari sir. And Vijendra sir's presentation, the best part of was the last part of trying to involve our spiritual part into academics. Thank you, sir. So now I'd invite the chairperson, Dr. Alpa Gupta, for chairing the session. Working presently as a professor department of pediatrics in the same institute, had also headed the department itself from 2016 to 29, and was in charge of the emergency department of HIMS for a year. Dr. Gupta was in charge of the Corona ward. He was a frontline COVID warrior and a member of the medical education department of the institute, active member of our own organization, IAP Uttarakhand, and basic coordinator and a coordinator for both the basic NRP and advanced NRP. Special interest, pediatric neurology and neurodevelopment pediatrics. So I welcome Dr. Gupta to please chair the session.
Thank you, Dr. Bhadra. Thank you, Dr. Bhadra, for your kind introduction. Good afternoon, everyone. It's an honor to be, sharing a platform with such big stalwarts of IAP and all over India. Dr. Basaraj, especially thanks to you and all other stalwarts of Central IAP for, conceptualizing this type of program for academics with institute, where our junior resident can showcase get an exposure and showcase their talents on a national platform. Dr. Satish Sharma sir, a special thanks to you for selecting our institute and motivating us to, literally pushing us to take part in this. Thank you very much for selecting it from the North Zone. It's a real honor. Professor Chauhan sir and Professor Devarari sir, Your presence and guidance has always been a source of inspiration and encouragement to all of us. The academic excellence our institute is exhibiting now these days is because of your excellent guidance. Dr. Chauhan has been in the medical education even before Medical Council of India pushed this medical education units into, made it mandatory. Even before that, Dr. Chauhan has been conducting medical education workshops in our institute for us, so that we can deliver the best of us to the students as a teacher. And Dr. Dhirari sir has, ever since he has joined, it's a boost to as a pediatrician, it's a boost to us, all the faculty members in the department. Thank you, Dhirari sir, for enlightening us and guiding us always. Now, let me formally introduce our HOD, Professor Anil Rawat. He's a colleague with me since 2000 when he joined this institute as assistant professor, and now he's become the HOD. He did his MBBS from Allahabad University in 2000, and he did his MD Pediatrics from Kanpur, where I also did my PG post-graduation. And after I completed, he joined the institute, but then when I met him, since then, he's been an excellent colleague to me. Dr. Anil Rawat, he has many publications. It's a huge list. If I, to sum up, many international and national journals, and a special interest in pediatric and neonatal critical care and infectious diseases. I invite now Dr. Anil Rawat to give an overview of the department, and also he'll tell us about the research work that is being done and it's still going on in our department. And over to you, Dr. Rawat.
Thank you, Alpa ma'am, and namaskar to all the stalwarts and all the listeners who have joined. And my job has been done easier by Professor Chauhan sir and Devrari sir. Most of the things they already told. Little bit I will take few time about the department. Himalayan Institute of Medical Sciences was established in 1994, whereas PG course in the Department of Pediatrics was started in 2002. So we are young, but steered by the experienced team leaders and energetic members. 2 MD seats were increased to 13 in 2020, and Department of Neonatology was born in 2021, running DM courses now separately. And fellowship in pediatric critical care was started in 2024. We have 4 functional units with separate Department of Neonatology. Department is fortunate to have Principal Professor Devrari sir, who also acting as chief architect in guiding us to scale newer heights. There are 3 professors. We are having a robust teaching program, daily undergraduate teaching, and 6 days a week postgraduate teaching. So there are 3 professors, including me, 4 associate professors, 3 AP, apart from SRs, JRs, nursing, and other staff, working day in and day out to achieve the motto of His Holiness Swami Rama, that is love, serve, and remember. Department is extensively involved in the research activity. 50 publication and 35 ongoing research projects speaks about it. That is in the past 5 years. Ambitious extramural projects funded by ICMR in collaboration with Rural Development Institute, Community Medicine, Obstetric and Gynecology, with the title of Sankal, that is strengthening program implementation and monitoring to achieve single-digit neonatal mortality It is a multi-centric extramural project rolled all over the country, and 10 districts have been selected. Haridwar district in Uttarakhand has been selected for this project from Himalayan Institute of Medical Sciences. Himalayan Institute of Medical Sciences is also a part of revising the standard treatment workflows by ICMR DHR. This document itself will work as a resource manual for the district residency program later on. There are 12 innovations and 3 patents have been filed from the department. Books published by the department are around 8 books, and mainly these are the major contribution are by Professor Devrari and Professor Girish Gupta sir. Himalayan Institute, Swami Rama Himalayan University is famous for many firsts in the Uttarakhand. One such example is the first bone marrow transplantation done in 2016. So far, 108 transplantation has been done with the success rate of around 70%. Our calendar is full with the academic activities, CMEs and workshops throughout the year. Foundation of the Uttarakhand Neonatal Society was laid down under the leadership of Professor Devrari sir on January 2023, and Institute also homes the secretariat for the same society. State-of-the-art skill and simulation lab provides great opportunities for the undergraduates and postgraduates for the learning on the real and virtual type of the scenarios. This lab is being used for basic and advanced NRP program courses like PALS and mechanical ventilation workshop and many more. UG and PG quiz is an annual event for us, and we are also aligning with the national program like breastfeeding week, and we have celebrated last year Autism Awareness Week. Throughout a week, the activities were done, and our anemia awareness program was also celebrated in this department. Latest, we have the state-of-the-art NICU 30-bedded with separate DM courses, and the 10-bedded neonatal HDU under the vision of Professor Devrari, and the 10-bedded PICU is the latest addition. Also, we have got a fully equipped ambulance to steer the sick child to and fro from the institute. We are not celebrating those healthcare movements only, we are celebrating our all good things in the departments. There are a few success stories which give you a smile at the end of the day, and they make your day. So now we are planning to have a separate mother and child healthcare blog. Thank you to the visionaries in the Himalayan Institute of Medical Sciences who have felt this thing, and they are pushing for the separate blog. And the private OPD blog and is already under construction. Thank you all.
Thank you, Dr. Rawat, for elaborating and highlighting the work that our department has been doing under your able leadership. And now I think before we are ready. Okay. So without wasting much time, let me invite our residents, junior residents for the presentations today, for which the whole platform has been created. So first case will be presented by Dr. Mansi Bansal. The moderator is Dr. Sanobar Wasim. She's an associate professor in our department. And Dr. Manju Kedarnath. He is assistant professor and also an intensivist. So Dr. Mansi Bansal, if you're ready, we can start.
Thank you, ma'am. Good morning, good afternoon, everyone. First of all, I would like to thank IAP for giving me an opportunity to present on this platform. I would be presenting case of Master A 14-year-old child who is a resident of Haridwar and presented to us with chief complaints of weakness in bilateral lower limbs, right more than left since 2 weeks, along with difficulty in walking since 2 weeks. Weakness was insidious in onset and was progressive in nature. Child initially had weakness in the bilateral feet in the form of not being able to wear slippers and difficulty in standing and walking. However, the child was able to walk with support. Within 2 to 3 days, weakness progressed to such an extent that the child could not squat and stand from sitting position without support. These symptoms were, there was no history of upper limb involvement, abnormal or decreased sensation in bilateral limbs, pain while walking or any diurnal variation, any signs of bowel and bladder incontinence, symptoms of cranial nerve involvement, symptoms of any respiratory muscles involvement. There was no history of fever, rashes, or any significant weight loss, headache, behavioral changes, vomiting or loose stools, any episodes of abnormal body movements, altered sensorium, or loss of consciousness. There was no history of any drug intake or any recent immunization, trauma, or recent IM injection. Coming to history of past illness, the child was admitted to us in August 2022 with complaints of fever, decreased appetite, headache, and vomiting for 15 days. CSF analysis was done, which showed a high protein of 289, sugar of 44, of a ratio of 0.4, cells 10, predominantly lymphocytes. Neuroimaging was also done, which showed basal exudates with multiple tuberculoma with normal ventricles. So the child was started on anti-tubercular therapy along with anti-epileptics from 12th June 2022. The child was discharged with approximate hospital stay of 15 days. However, 1 week post-discharge, the child again presented to us with complaints of headache. This time, neuroimaging showed non-communicating hydrocephalus along with papilledema. So, VP shunting was done and dexamethasone was given for a total duration of 3 months. The child was discharged after 2 weeks with no neurological deficits. The child was with regular follow-up with us in the OPD, and of repeat CT done 1 year later showed cisternal head granuloma with basal meningeal enhancement. So ATT was continued for 3 more months, and a repeat MRI was normal with no neurological deficits, and the ATT was stopped. The child lost to follow-up after stopping ATT until he became symptomatic after 3 months and presented to us with these complaints. The birth and developmental history was normal. The immunization history was incomplete. No documents were present, and child had received last vaccination at 5 years of age. However, BCG scar mark was present. The family history was insignificant with no history of any TB contact. The personal and dietary history was normal for the age. Coming to the general examination, the general condition was stable with all vitals being normal, with a heart rate of 88 per minute, respiratory rate of 24 breaths per minute, temperature 98.3 degree Fahrenheit, blood pressure of 170 mmHg, and saturation normal on room air. The anthropometry of the child was normal, with weight for height being 100%, and the child had attained an SMR stage of 3. The child had pallor and icterus, cyanosis, clubbing, lymphadenopathy, and edema were absent. The child had normal head-to-toe examination with patent VP shunt, and no neurocutaneous markers were present. Coming to systemic examination, CNS examination, the higher mental functions were normal. The child had had a GCS of E4, V5, M6 with normal speech, behavior, and attention, normal concentration and attention with normal memory and emotional state. Coming to the sensory system examination, there was hypoesthesia present between the T10 to L1 levels. Coming to the motor system examination, the child had bilateral normal symmetrical bulk with no signs of atrophy. There was hypertonia of bilateral lower limbs, right more than left, with rigidity. However, the tone in bilateral upper limbs were normal. The child had a power of 5/5 in bilateral upper limbs. The power was 4/5 across all muscle groups in the left lower limb. And in the right lower limb, hip and knee flexors had a power of 3/5. However, extensors of both hip and knee had a power of 4/5. The power at ankle at right joint, the dorsiflexors had a power of 2/5 and plantar flexors of 3/5. Cranial nerves were intact. In reflexes, corneal reflex was present. Rest all superficial reflexes were absent. Bilateral biceps and tricep jerk was normal. The child had brisk knee and ankle jerk with presence of ankle clonus. There were no signs of cerebellar involvement. Meningeal signs, involuntary movements were normal. The child had a lurching gait with spinal tenderness at D7, D8 level. There were no signs of any autonomic system involvement. So, on the basis of history and clinical examination, we ruled out certain differential diagnoses. A first was post-tubercular sequelae. Points favoring was that the child was a known case of tubercular meningitis, also had neurological deficits present, along with tenderness at D7 and D8 level. However, the child had a good ATT compliance for 16 months and was discharged with no neurological deficits. Second differential which came to our mind was port spine, as the child was a known case of tubercular meningitis with neurological deficits and tenderness. However, the child had continuous good compliance of ATT. Third differential was transverse myelitis, as there was hypoesthesia present between D10 to L1 level and exaggerated DTR at the time of presentation. However, the child had asymmetric weakness without any signs of bladder involvement. A last differential included Guillain-Barre syndrome, as the child had ascending motor paralysis with no bladder involvement. However, the child had asymmetric weakness and sensory involvement was also present along with exaggerated DDR. We also thought a possibility of syrinx, as the child had neurological deficits along with spinal tenderness. However, there was no root pain, saddleback anesthesia was absent, and there was no signs of cranial nerve involvement. So we did a MRI spine of the child, which showed a peripherally enhancing lesion at D7 to D8 level with significant spinal cord edema. Along with this, we also did a MRI brain screening, which was normal. The CSF examination of the child had no cells with a normal glucose and a high protein count. The gram stain and culture was sterile, and CSF TrueNat for PCR was negative. We had planned on sending MGIT and LPA samples of the child, but due to financial constraints, we could not send it. Course during hospital stay, the child was restarted on anti-tubercular therapy, and after the neuroimaging, pulse dose of methylprednisolone was started. After neurosurgery consultation, a T7 to T8 laminectomy was advised, but it was deferred as the child had shown clinical improvement. Thalidomide was added on day 9 of admission. Gradually, the power and the hypoesthesia improved, and child was discharged on tapered dose of oral methylprednisolone. Currently, the child is off methylprednisolone and is on regular anti-tubercular therapy and is on regular follow-up in our OPD. So this is the condition of the child at discharge. The child was made with the final diagnosis of dorsal spinal tubercular abscess. So this is the video at the day of discharge. So the take-home messages we learned from this case were: the child was well managed. The child was Early spine screening should be done, especially in high-risk symptomatic cases in which we suspect early post-tubercular sequelae. And when we are diagnosing a case of tuberculosis, along with prevention, early diagnosis and treatment, post-tubercular care also holds an important aspect in treating a child, and regular screening and follow should be done when the child comes to us for follow-up, along with compliance of the ATT. And conservative management has equally good results, as we were advised surgery, but as the child showed good results with the conservative management, we continued with the conservative management, and now the child is well and is on regular follow-up with us. Thank you.
Okay. The house is open for question. Anyone?
Dr. Alpa, I want to know one thing. The child had CBNAT done on CSF earlier, and was there any element of CBNAT was sent for CSF specimen?
Yes, sir. The CBNAT was sent on both the occasions when the child was admitted with us. However, both the time it was negative.
Okay. And secondly, how will you explain the child has received ATT and now these lesions have occurred even after the full compliance of the treatment? What is the explanation? Now this improvement is only because of the steroids and something else we are missing out.
So I think the patient had improved on taking on ATT this time. Methylprednisolone or probably and thalidomide has been started. So I think we are still following this patient, Dr. Mansi. Dr. Sanobar, you want to add something?
Sir, actually, it was an interesting case. There have been reports where after complete treatment with anti-tubercular drugs, there have been relapses or reinfection. Although when we search the literature, there have been such cases reported with sputum positive pulmonary tuberculosis, where all the things have been resolved, even radiological clearance has occurred and the patient has been reinfected or there has been a relapse. We could not find any CNS case. One thing that was missing in our case, and I don't think, I would not say actually missing, because there is no clear-cut guidance which says that if you have a case of CNS tuberculosis or cerebral tuberculosis, you need to do a spinal screening also. We did not do a spine screening in the earlier, when the patient presented to us earlier, because he did not have any symptoms suggestive of spinal involvement. So we still don't know whether it was a relapse, some lesion that were left in the spinal cord, which reactivated after that. So we had two differentials, either a relapse of the previous case or a reinfection of the port spine after treatment with the previous.
Only element could be the element of resistance in this case. That only
Yes, definitely. But the only thing that was a bit dicey about resistance was that the patient did not have any neurological deficit throughout his course of treatment for CNS tuberculosis. And also when we did an MRI before stopping the treatment, the MRI showed the clearance of all the tuberculomas. So that was something but definitely we cannot rule out drug resistance in this case. We had planned for sending other investigations to isolate tubercular bacilli from any other lesion also. The patient is on follow-up and we are even planning to do an invasive procedure in the spine if the patient does not improve or shows relapses again, so that we can isolate some material from there and then send it for culture or drug sensitivity or organism oscillation.
And what is the role of thalidomide? Last question.
So thalidomide binds to cerebron, which is a part of beta ligase pathway, and so it inhibits TNF alpha and TNF kappa, which helps in proliferation of these cells. So recent literatures have been done which have shown results in adding of thalidomide in tubercular meningitis. So still
You are giving it for spinal lesion now, no? Is there any indication? Now you are treating it as a tuberculosis of the spine.
But it also reduces inflammation since it acts on the inflammatory pathway. So it has good results in supportive management while reducing inflammation also.
If I may come in here, very good presentation. Only 2 or 3 issues, madam. One is that, as Dr. Lalit mentioned, we don't have bacteriological proof here. We have only radiological proof of tuberculosis. The second issue is, the question comes in, is that you have found a new lesion after complete treatment. A new lesion after complete treatment can be due to 3 main reasons. Reason number 1 is it could be a tuberculous lesion there. It could be a non-tuberculous lesion there. And the third possibility is it may not be an infectious disease at all. It could be something else. So I think what we need to do is to follow up this child very carefully. Coming to thalidomide, thalidomide was first used in South Africa for children who had immunological hyperreactivity after starting treatment. That is, when they had an immune reconstitution syndrome, thalidomide was useful to reduce the inflammatory lesions. And here the point is that this could have probably occurred when you started treatment initially for tuberculous meningitis. But right now, I think still we are not very clear what this lesion is. It may or may not be tuberculosis. The last point which I wanted to mention is, I'm sure that you must have done an HIV here,
Yes.
which is a very important investigation to rule out recurrence of tuberculosis.
Yes.
One more point which I would also emphasize is that in olden days, during Dr. Udani's time, we used to see patients who, when they had a injury to any part of especially if they had a head injury or a back injury, could relapse with tuberculosis, because there is some activation that could take place if a hematoma happens there. So another point in history would be to find out whether any of these children, whether this child had a history of injury to the spine, which could have precipitated the infection.
So the child had no injury in the past, or we had inquired, but he did not have any injury.
Thank you.
Very interestingly, I would just like to add, very interestingly, we have another patient is still admitted. We are still managing, who presented with the signs of tubercular meningitis, and we were able to, radiologically find the proof of tubercular meningitis. And when we started, but before we could start ATT, she also started having signs in the lower limb. That was during her admission stay only. I think within a span of 2 or 3 days. And then we did the screening of the spine, and then we found that the patient was having erythroiditis also. So now the patient is on ATT, full-fledged ATT, and she is improving along with the steroids. So adding to the two, I think this is a learning lesson for us, that whenever we have tubercular meningitis, we should screen the spine. We never have a guidelines like that. Dr. Chauhan is an orthopedician, probably seeing more of sports spine. Sir, would you like to add anything to this? Chauhan, sir.
Yeah. So I think it was a very good case you people have presented, and it's an eye-opener also. But what I felt, that unless and until you have a tissue diagnosis, it will become difficult. So I do not know why you people not have gone for interventional to get a biopsy from the local lesion.
So probably it was deferred by the surgeon because the patient was improving. Am I right?
Yes.
You see, these improvements can be temporary because of the steroids also. So you see, as even Dr. Jagdish mentioned, you see, we need to have a biopsy done. It can be a CT guided biopsy, but at least some tissue should be obtained so that at least we have some idea. Otherwise, we'll be just simply beating around the bush.
Right, sir. I think patient still is on follow-up. We can still look into that.
That is what has been planned.
Yeah, probably we can plan it now when the patient comes for follow-up. The patient is otherwise doing well. She's improving. So with your permission, I could go to the switch to the next case. The second case for today will be presented by Dr. Manjot. And the moderator for this case is Professor Ashish Simalti. He is an intensivist who's also heading our ICU unit, which is a 10-bedded ICU, state-of-art PICU, and along with Dr. Rakesh Kumar, who is an associate professor in our department. Dr. Manjot, are you ready?
Yes, yeah.
Please start.
Good afternoon, everyone. I'll be presenting the case 2. It's a 5 months-old male baby of Miss P who presented to our emergency with the complaints of fast breathing for past 1 day with bluish discoloration in the perioral skin area, one episode of abnormal body movement in which uprolling of eyeballs was noted and lasted for around 2 minutes. Going to the birth history, baby was born to a 28-year-old gravida 2 female in a hospital via normal vaginal delivery through a non-consanguineous marriage with the birth weight of 2.4 kgs and was discharged within 48 hours on breastfeeds. At home, baby continued to have mixed feeds as mother felt that the breast milk was inadequate. And later on, due to poor suck, baby was shifted to bottle feeding. On developmental history, there was a delay in motor domain, both in gross motor and fine motor, in which bidextrous reach and neck holding was absent. However, the language and social and adaptive domains were normal. On day 30 of life, the baby developed cough, in which there was no diurnal variation or any episode of post-assum vomiting. On day 42, he developed loose stools, in the form of which were watery, non-blood and bile stained. And on the same day, he developed respiratory distress in the form of fast breathing and noisy breathing. For these complaints, they went to a private hospital where, in view of severe respiratory distress, the baby was intubated and kept on mechanical ventilation. Chest X-ray was done, which was suggestive of right upper lobe collapse. Their extubation trials were done. 2 of them got failed. Repeat X-ray was done, in which unresolved collapse continued. So bronchoscopy was done, and the lavage culture came positive for pseudomonas. CT chest was done for the same, and left-sided collapse was seen along with pneumothorax of the right, in which the ICD was placed, which was removed later after 3 days. Then CFTR gene testing was done, which came out to be negative. After all these conditions resolved, with the total ventilation days for 24 days, the baby was discharged at an age of 3 months, 8 days with the weight of 3.2 kgs on room air and was kept on NG feeds. Over the next 2 months, baby continued to have occasional episodes of rapid breathing and cough. So when we look back at the history again, we see that at birth, he was able to have breastfeed, had a proper suck and swallow according to the parents. Then after a few days, he shifted to bottle feed because of decreased sucking. Then in the first hospital stay, NG feeds were initiated due to the critical illness. However, later on it persisted. Maybe it was because of the disease progression. Baby presented to our emergency on NG feeds. So the baby who presented to our emergency with respiratory distress, on evaluation, the airway was open and maintained. On breathing, there was respiratory distress in the form of tachypnea, moderate intercostal, subcostal, and xiphoidal retractions, with the bilateral air entry reduced and expiratory wheeze and creps being present. Hemodynamically, the baby was stable and was alert and afebrile. On CNS system examination, high mental functions, cry was present. However, there was lack of spontaneous movements of the limbs. All the cranial nerves were intact. On motor system examination, frog-like posture was seen. Tone was decreased in axial and appendicular system, and power could not be assessed, and areflexia was noted. Sensory system was intact. Anthropometry, weight was below the 3rd centile, and head circumference and length were almost on the 3rd centile, indicating towards failure to thrive. Day 1, the baby was admitted to the HTU and kept on triple HFNC support. On day 2, HFNC support continued. However, he developed bradycardia, for which he was intubated and shifted to PICU. Over day 3 to day 6, the ventilator settings were tapered and extubation was tried. However, it failed. So when we are looking at a case of hypotonia with respiratory distress, we've seen areflexia, weak suck, motor delay, repeated respiratory complaints, and alert look, pointing towards peripheral hypotonia. And level of lesion could be at the level of neurons, neuromuscular junction, or at the muscular level. So our provisional diagnoses were kept either SMA, myasthenia, or myopathy, congenital myopathic disorder, or muscular dystrophy. There was no ptosis or ophthalmoparesis seen. CPK was normal, so myasthenia was ruled out. And for myopathic disorders, there was no facial or ocular weakness seen, no dysmorphic facies. CPK was also normal, and an MRI brain was done in which nothing was noted.
However, all the points pointed towards SMA with the history of repeated respiratory infection, areflexia, motor delay, no facial dysmorphism, uniform hypotonia, and repeated ventilation tapering failure. So our options to confirm it were either whole genome sequencing or MLPA. We went for MLPA because we needed a targeted analysis. Also, it has a lower cost and a shorter turnaround time. It has been included in many countries in their newborn screening to screen for SMA. On day 7, the targeted genetic test was sent, which came out positive on day 14 for SMA. So what is SMA? It is an autosomal recessive disorder in which there is degeneration of anterior horn cells leading to muscular weakness and atrophy. There's an incidence of 1 in 1,000 live births with carrier of 1 in 50. Two major genes play role in it, SMN1 and SMN2 on exon 7 and 8. So SMN1 plays a pivotal role in SMA. SMN2 is less efficient in making the functional SMN protein. So in the report, we have seen that SMN1 gene, both of them were absent. So we suspected SMA type 1, in which the age of onset in our case was of before 6 months. Muscle weakness was noted, inability to hold head was seen, steady or sit independently was not there. Sucking and swallowing challenges were noted, and breathing difficulties were present. On day 15, the attendants were counseled for the same and tracheostomy was done and the patient was shifted to SIMV PCV mode. On day 19, it was tapered to the CPAP support, and on day 21, it was shifted to BiPAP support. On day 36, the baby was shifted to HDU, and over the days, the settings were tapered and chest physiotherapy continued. And on day 46, the baby was discharged on NG feeds on portable BiPAP with the settings of IPAP to EPAP of 12:5. So major role of this in this case was of genetic counseling, in which parents were counseled regarding the genetics and offered carrier screening. Both the parents came out to be carriers for SMA, and risk in future pregnancy of 1:4 was explained to them. Psychosocial support was provided and antenatal screening was suggested for future pregnancy. Treatment options. The only treatment options we offer may bring about functional improvement and extend their life expectancy. Available in India are only nusinersen, comes under the brand name of Spinraza, and FDA approved are other onasemnogene and risdiplam, which are not approved in India currently. So why we went for tracheostomy in this case? Parents were explained both the pros and cons of it and helped in making a proper decision. Points in favor of it were that it provided secure airway, freedom from prolonged mechanical ventilation, and against it were that it could be a burden of care for the families, and the patient had overall a poor prognosis. Parents made an informed decision and they chose for it. Take-home message would be that we should suspect SMA in all cases of hypotonia. Our case was hypotonic since birth and it got recognized at a very later age. Genetic counseling is essential upon SMA diagnosis, providing crucial support for families to understand the condition's genetic basis. By embracing genetic counseling and collaborative care, we empower families affected by SMA to navigate their journey with knowledge, support, and resilience. Tracheostomy in SMA who are ventilator dependent can help in reduced hospital stay. I would like to extend my thank you to IAP for providing this enriching platform to us. Thank you.
Right. Very nice presentation, Dr. Manjot. To say that we were not able to diagnose it on time, I think that's an over-exaggeration. I think at 5 months, you were able to diagnose hypotonia and diagnose the patient to have SMA. It's a real, support to the family, I would say. But otherwise, most of these patients will go into a cycle of repeated respiratory infections, where most of the hypotonia will be attributed to the infection part. And then, again, they end up, and only at a later stage, when they are diagnosed to have SMA, somebody would think of it. So I think it's an excellent job. Only one thing that I would like to ask is, you mentioned that the patient on the admission had upper lobe consolidation, right? which was diagnosed to have, on lavage had pseudomonas. So probably the presentation was of pneumonia, but this X-ray which was done after the intubation or prior to the intubation. Can you elaborate on
The
that?
X-ray was done prior to the intubation and it was done in an outside hospital. This was the course of an outside hospital.
Okay. Then that means the consolidation was, there was a consolidation in the Apollo. Why I asked this question was, normally after intubation, if the intubation is not proper, Apollo consolidation can happen if it is, the tube is slightly into the right bronchus, because the Apollo bronchus comes immediately out of, as soon as the right bronchus, the trachea divides into right and left bronchus, the Apollo bronchus comes out. So a little bit of misplaced tube also can lead to all these problems. So if this was before, that tells us, okay, this wasn't, and this pneumonia was pneumonia and not an aspiration, am I right? Yeah.
Yes.
Was there any evidence of aspiration also prior to this pneumonia?
No, ma'am.
No history. Dr. Ashish, you would like to add something?
Thank you, ma'am. So it was a good case to diagnose, but ultimately not a good case to inform parents. So these are the cases where there's a futility of the treatment that becomes a very ethical dilemma for us, how to counsel and how to guide parents. Because the treatment now, when they look at the internet, they say treatment is available. But how practical that treatment is, how feasible that treatment is, that also needs to be taken into consideration. Because then they came with a lot of information that this is the treatment we can do and all. Then we had to tell them that all this information is actually evolving only. And actually this Spinraza works in a pre-symptomatic neonate. Hence the role of neonatal screening. Once the symptoms are already there, then this may not be that effective. These are the challenges with these cases.
Any other question?
JC sir, you would like to brief on the treatment part? Yeah.
A wonderful presentation, and I'm sure that these are challenges that are faced by us whenever we're faced with a life-limiting illness like SMA. I would just bring to the attention that in Bangalore, we have a center which is offering treatment for SMA patients. And it's very, very expensive. What you mentioned, both the gene therapy and the Spinraza, which is available. The other thing which we have done right now is to train people on home ventilation. So we help these parents take care of their children at home with ventilation. And right now in our home ventilation program, we have more than around 500 children with neuromuscular disorders. So there is a scope to help these children at least for till the time they are the same. And in fact, many of these children are even 14, 15 years of age, continuing with home ventilation. So I think it's important that maybe you could connect with our team in Bangalore, who could help you out with maybe setting up a service within your hospital for such patients.
I think that's a very good suggestion. I think we should take this and collaborate with you, sir, and then maybe we'll be able to help this child much better. And I must add, Dr. Ashish was, is an intensivist, and the patient was managed under his care. Also, and it's commendable that the team, their work has been there in managing this patient.
Thank you.
So I think we are overshooting. Am I right? The time?
Yeah, right on time, ma'am. Thank you. Thank you so much. I would now request our past president, respected Dr. Pramod Jog sir, for his jogisms. That's what JC sir has titled it as jogisms. We are eagerly waiting for your remarks, sir.
Oh, thank you, Dr. Priya. And I'm so glad that I knew Dehradun only for Amitabh Bachchan and Rajiv Gandhi, who were, supposedly the students of the Doon school, the very famous school. But now I know that there is a third entity existing in Uttarakhand, and that is our pioneer medical institute of the North India, and that is HIMSS, or the Himalayan Institute of Medical Sciences. And Dr. Vijendra Chauhan, in the beginning, gave a very different, outlook of this entire institute. I never knew that it's the vision of Swami Rama, who was a yogi and a philosopher. And probably the institute is the one where, science meets yoga. We are all scientific people, but then, we have started believing in yoga also. And the information that he gave about the control of the blood flow and the heart and the control of the brain waves was quite fascinating. And it appears that there is an integration of the ancient wisdom with the modern technology. And I was also rather impressed by that information that he gave about that pneumatic chute system for blood samples, okay, and the Ayurvedic Center and the community involvement of this institute, where they are serving almost 2,000 villages in the mountains with the ASHA workers, wash, that water and sanitation and toilets and all, okay. So basically, I must congratulate for this combination of body, mind, and spirit that he said. And followed by that, of course, Dr. Ashok Devrari. Again, the initial three alphabets of Dr. Devrari is DEO. They are close to the Dev Bhoomi, isn't it? Because Uttarakhand is known as the Dev Bhoomi, and he is the principal. And I must say that he gave all the 6 important pillars of neonatal care related to the preconceptional care and the antenatal care, the labor and the childbirth, the immediate newborn care, the essential newborn care, the care of the small and the sick, and the care beyond survival. So these are, the India Newborn Action Plan pillars from 2021 to 2030. And, what I appreciate is that the 10 low-cost interventions which he mentioned. Some of them in the antenatal care, like antenatal steroids, and then in the natal care, like the skin-to-skin contact, the delayed cord clamping, the early initiation of breastfeeding, and the family-centered care. And in the neonatal period related to the neonatal resuscitation, also the proper use of oxygen, the express breast milk, kangaroo mother care, and the rational use of antibiotics. So all these important 10 interventions, he told us that almost 70% of the neonatal deaths can be prevented by these low-cost interventions. And, these interventions are well studied. They are scientific and evidence-based. That's very important. And that's why I must say that, the IAP, our members are the ambassadors for the neonate, and they will strive hard, I'm sure, for infection, asphyxia, and prematurity. That is another IAP. These are the 3 important causes for the neonatal mortality. So IAP will definitely work for IAP. And then at the end, he gave all the information which was in those 4 C's related to this communication and coordination and convergence and cooperation. So all those in different sectors and different players could be involved. So I congratulate Dr. Devrari. I am, sure that the institute is in safe hands with the leadership of Dr. Devrari, and he has a great experience of the past. And of course, 2 cases where I must say the preparation for the PGs for their MD exam, because both of them were the long cases for the neurology, which we always take the students to the task, and presented by Dr. Mansi along with Sanobar and Manju, the case of that dorsal spinal tubercular abscess. What I liked most was the analysis of the case. The diagnosis was a bit in doubt, and we learned that every child with TBM, you must have this early spine screening. And of course, though there are some challenges related to diagnosis, whether it is TB or not TB, and suggestion to have the tissue diagnosis, they are definitely, certain issues in this case. But all said and done, the differentiation between the, a child who is having, whether it is a post-TB sequelae, or whether it is, a port spine or a transverse myelitis or Guillain-Barré or syringomyelia. So all those, points were very well analyzed. And I'm sure in MD exams also, we want to see the approach and not the final diagnosis. So I think that's a very good thing. And the other case presented by Manjot and moderated by Ashish with Rakesh Kumar, that 5-month boy with the respiratory distress with peripheral hypotonia. Now we will always remember to keep 3 things: the spinal muscular atrophy, the myasthenia, and myopathy at the back of mind. And any child with hypotonia, we will suspect spinal muscular atrophy. And the importance of genetic counseling and tracheostomy in ventilator-dependent children, reducing the hospital stay. Of course, Jagdish rightly pointed out the ethical dilemma and importance of the home ventilation and the facilities available. So I think today's program was a very, very, very great program for students, because in the beginning only Dr. Chauhan made it very clear that we have to receive, retain, and multiply. He used these adjectives for love, but I must say the adjectives can very well be extended to the knowledge in the brain. You have to receive, you have to retain, and then multiply. And Dev Bhoomi is very close to the Ganges, the Ganga, and I'm sure the entire the group of students and the faculty will remain immersed in the Ganges of the knowledge, and the institute will reach Himalayan heights in the coming future. And as one of the speakers, I think Dr. Anil Rawat, who gave the overview of the department and the research activities, and also told about the books by Dr. Devrari and Dr. Girish Gupta and the first bone marrow transplant in the institute. I must say that he mentioned that the logo of the institute says it is love, serve, and remember. So that I think these three terms are very close to pediatric practice. And whenever I get an opportunity, I will love to attend that course on science of joyful living.
Honor to have you.
Science of joyful living, which someone mentioned. And because some of these are important issues, and as we progress in our pediatric practice, we come to understand the importance of some other things also. So I wish that this institute, which has bagged the award for Ayushman Bharat, becomes Ayushman and lives long and is of great help to the community at large. Thank you.
Thank
Okay, there
you.
are certain comments before we end. There are certain comments on the chat box. Let me read out. This is for the second case. Genetic counseling is most important to prevent such type of diseases. I think the message is well taken. Dr. Ashok Durari sir has written good summarization. Dr. Pramod Jog. Then I think it's Dr. Srinivasan. He's writing. Sir, you're here. Dr. Srinivasan, you're here.
I'm very much here. I'm very much here.
So please, I'm reading your message on the chat. Icing on the cake is Professor Dr. Pramod Jog's summing up the entire proceeding in his humorous manner without missing essentials. So we enjoyed Dr. Jog. We also share the same feeling. Dr. Jagdish is still here. He's writing on the chat box. Fantastic program. Thank you all. Thank you. It's an honor to be sharing screen with you all. I would say screen because there's no platform here. So we've taken the screenshot, by the way. So I don't know whether Dr. Priya you have taken or not, but we have taken some. I'll share them with you.
Yeah.
It's a real honor to be with all the stalwarts. And Dr. Chauhan, I should not forget to mention, he is the member of the presidential body for our institute and a steering force for our academics in this institute. But before we end, we have a small video. Sorry to overshoot the time, but I'll say that please bear with us. A very short video. We'll leave you with this. Thank you very much.
Thank you so much to the whole department. I think first time we had a holistic view of the program today. We all are grateful, from the academics of institution team to the faculty of Himalayan Institute of Medical Sciences. Thank you so much. I would request our North Zone coordinator, Dr. Lalit Mendiretta sir, to deliver the vote of thanks.
Thank you, Dr. Priya. I think much of the job has been done by Dr. Pramod Jog already. But it is really a beautiful place, beautiful people, and beautiful institution. I think it's all go together. From today onwards, many of us will be willing to see and visit that place anytime. And it is really from my heart, it's so heartening to thank, Himalayan Institute team led by Dr. Vijendra Chauhan sir, Dr. Ashok Diwari sir, Dr. Alkwa Gupta, who handled the show of the 2 cases presentation, Dr. Anil Rawat sir, and of course, the faculty team, the PGs, Dr. Mansi, Dr. Banjot, and moderator, Dr. Professor Rashid sir. So from Central IAP, we all thank you for the brilliant 2 cases and the brilliant presentation you did. And we came to know about your beautiful institution. And it is really a congratulation message to Central IAP led by Dr. Basav Raja, Dr. Yogesh Parekh, Dr. Atanu, and all our Vice President, Dr. Satish Sharma, Dr. Siravalu, and other 3 Vice Presidents who are not there. And for this 12th edition of Academic Institution Program, which is running successfully for last 3 months. And Dr. Jagdish is the scientific coordinator, who is really always, enthusiastic about this program, sir. And finally, Dr. Jog, sir, thank you. And Dr. Srinivasan, who always joins us. And I thank my all EBs and those who have joined the program today. And finally, the last thank you to Dr. Priya, who always works every Monday to Friday for this program. And she has been working relentlessly for three months. Thank you very much from Central.
Thank you, everybody.
Thank you.
Good night, all of you.
Thank you, sir. I would request all the viewers to join in back on 12th April. We are having Assam Medical College from Dibrugarh. Request all of you to join. From the East Zone, we are having the next session. Thank you all. Thank you so much.
Thank you, everyone.
Thank you, everyone. Bye-bye.
Thank you, sir. Thank you. Thank you, sir. Thank you, Dr. Ashok, sir.
Bye.